Hello and welcome to our lecture about antimicrobials that target tuberous sclerosis, or TB. Here is our outline. We're going to talk about Mycobacterium tuberculosis. It's a bacteria that causes TB, and it is very different from other bacteria. So we use very different drugs to fight it off. We're going to talk about the right treatment that we use for TB, which just includes Rifampin, Isoniazid, Pyrazinamide, and Ethambutol. It's just one of the few times where you have to know all the drugs that we use to treat this infection. And then there is sometimes we may use Streptomycin if it's sensitive. Let's talk about what makes TB different from other bacteria. One of the big things that makes it different is going to be the mycolic acid layer on the outer membrane. And this is the prime target for isoniazid, which is in our right treatment. Another thing that it makes it different is that it uses arabinoglycans, which you're going to see right around here, that hold and anchor the mycolic acid layer to the cell surface membrane. And this is the prime target for ethambutol, which is also inside of our right treatment. Something you need to know about TB is that it has a tendency to mutate very often. So a lot of the times if you only use isoniazid and ethambutol, it'll eventually develop resistance. We're already seeing resistance in places like Russia to isoniazid and ethambutol. So it's important for us to add rifampin to this treatment to prevent the resistance of other drugs, because what rifampin does is it prevents messenger RNA from happening, from being made, and it prevents resistance from developing. Something else you need to know about TB is that they actually live in macrophages. They get into the macrophages' phagosomes, and they prevent the phagosomes from fusing with lysosomes. And even if they fuse, they actually inhibit the acidification of the lysosomes. What we can do is we can add pyrazinamide, and this pyrazinamide actually is activated when it gets into the macrophages. So it works well in that it increases the acidity of the pH in the phagosome and can actually help kill the TB while it's trying to hide in there. Let's talk about rifampin. Well, remember rifampin, it starts with an R, it inhibits RNA polymerase. So when the bacteria can't make RNA, it can't really adapt. And this is the first letter in our RIPE treatment protocol. It's often used for TB, but it can also be used for leprosy. Something else that you want to think of for rifampin is that it can be used for meningococcal or H. flu prophylaxis. So you want to not necessarily the person who has the disease, but the people who have been in contact with meningococcal or H. flu. You want to give them this as prophylaxis to make sure that they don't develop the disease. Some bad side effects that you want to look for with rifampin is hepatotoxicity, but the most often complaint for it is going to be the red or orange body fluids, and that's another R, reddish orange kind of body fluids that build up. The drug interaction that it does is it ramps up, that's another R that you get with rifampin, it ramps up the P450 mechanism. So what that means is that if you're ramping up P450, if the patient is on warfarin, that means is that P450 is going to work extra hard to metabolize that warfarin, and it can put the patient at risk of developing clots because their warfarin is no longer working. So you have to watch that out. And another thing is that oftentimes HIV patients also get TB because they're immunosuppressed, and so a lot of their antiretroviral drugs use P450, so you want to make sure that it's not being used at the same time. So you probably want to pick Rifabutin with an HIV patient so that you don't affect the P450 patient for the P450 enzyme, and you don't affect the patient's other drugs that they may be using to treat HIV. This is very important that it can develop resistance if you give it as a monotherapy. We never give these drugs alone. We have to give them as all together because TB is very prone to mutation. And if it develops a mutation resistance to rifampin through changing its RNA polymerase, it makes it more likely to mutate for all the other ones. Let's talk about isoniazid, which is likely the most high yield drug that I'm going to talk about in this lesson. It works by first going into the bacteria and then being activated by bacterial catalase peroxidase that is expressed by the CATG gene, which will be important when we talk about resistance. So after isoniazid is activated, what's going to happen is that it's going to inhibit mycolic acid synthesis. If you can't make mycolic acid, you can't make the outer membrane in the TB. Some important adverse effects that you need to memorize is the hepatic toxicity. All of our patients with isoniazid need to have a regular liver function panel to make sure that they're not having some form of liver failure. Something else that they do is that isoniazid inhibits the P450, so that can cause a lot of drug interaction. And it's very easy to remember because the abbreviation for isoniazid is INH, which is kind of like inhibit. Some very rare side effect, but nonetheless it's very unique to isoniazid and maybe 2 or 3 other drugs, is drug-induced lupus, or SLE. So drug-induced lupus is often presents with this butterfly mal or rash, or also in the photosensitive areas, like your arms and your cheeks. But it can also involve your kidneys, some sort of autoimmune reaction to your kidneys. Another thing that's very unique to isoniazid is the B6 deficiency. I don't think I know any other drug that can cause a B6 deficiency, but B6 is going to be very important for 2 things. It's very important for making myelin sheath in the neurons, so you can develop a neuropathy or peripheral neuropathy if you don't have enough B6, but it's also very important for the heme, and it can cause a sideroblastic anemia because your body just has no heme, and it can cause an anemia. You don't have any way to make red blood cells that can actually carry oxygen. So what you have to do with every patient that's taking isoniazid is give them the pyridoxine supplements, and pyridoxine is just B6. The resistance, as I mentioned earlier, is going to be the underexpression of CatG. If the TB learns that if it turns off the CatG gene, it won't activate the isoniazid. It can actually develop resistance to isoniazid. All right, pyrazinamide. This has a very simple mechanism. It's first taken up by the macrophages, and then it's activated into pyrazinoic acid. We may not know the exact mechanism after that, but we do know that usually when TB gets absorbed into macrophage, the macrophage has a hard time raising the acidity of its phagosome or phagolysosome. So what this pyrazinamide does, as we found out, is that it actually increases the acidity, which then damages the TB, and then TB can then be broken down into soluble debris. The adverse effects of pyrazinamide is hepatotoxicity. That's not really often asked, but the one that is often asked is going to be gout attack because it does cause hyperuricemia, or a high uric acid inside of your blood. So the only thing you need to know of the mechanism for that is pyrazinoic acid actually competes with uric acid. They actually use the same transporter. So if pyrazinoic acid is trying to exit your blood at the same time as uric acid, it might cut in line a bit, and that can cause a buildup of uric acid, and it can give you symptoms of gout, which often affects your big toe. Ethambutol. Ethambutol works by inhibiting arabinosyl transferase, and when you inhibit that, then you can't polymerize your arabinose. And if you can't inhibit the arabinose, you don't have that anchor. So if you can look over here, arabinogalactan, this over here, is actually anchoring the mycolic acid layer down to everything else. So if you don't have that anchor, what happens is that the TB bacteria is more prone to bursting. The adverse effects of ethambutol is going to be red-green colorblind. That is very important. It's a very unique side effect to ethambutol. And I try to read ethambutol as ithambutol instead of just ethambutol, ithambutol. And you just know that this is a reversible red-green colorblind. When the patient stops taking it, they can get back to it. I showed you over here a colorblind test. If you are colorblind, this will just look like a bunch of little dots, or it might look like a different number. But if you can see colors really well, you'll know that this clearly spells out a 16. Let's talk about streptomycin. If you've listened to my previous lecture, you'll know that it's an aminoglycoside. It's an old version that's not very often used. But one of the uses is, for nowadays, is TB. If TB is sensitive to streptomycin, you might want to just add that on there. But it's getting harder and harder to find TB that is sensitive to it nowadays. how it works is it inhibits the 30S and it prevents initiation. So I've showed you over here, aminoglycoside like streptomycin will actually get into the 30S and it'll prevent this messenger RNA from really attaching. So if you want to learn about the adverse effects, it's going to be exactly the same as aminoglycosides, but the two big ones is going to be ototoxicity and nephrotoxicity. And I remember that by remembering that there are loops up high and loops down low. Or in other words, there are loops in your ear, the semicircular canal, and there are loops in your kidney, which is going to be the loop of Henle. How do I use this information? This is one of the few times where I ask you to learn all the antibiotics that are used to treat this bacteria, TB, because we have to use all of them at the same time. So not only do you need to know the ripe mnemonic, but you need to know the mechanism. The mechanism of these drugs are very unique because TB is a very unique bacteria. And the drug interactions, they're very important drug interactions that you're going to find here. Rifampin ramps up the P450 while INH inhibits it. So there's a lot of ways that they can use this. And a lot of the patients that have TB are often have HIV as well. So you don't want the drugs to interact too much because you don't want to treat their TB while reducing their effective treatment on their HIV. And you need to pay very close attention to the adverse effects. They're all very, very unique. Rifampin turns all the secretions orange. INH hurts your nerves and your liver. Pyrazinamide causes gout attacks. And ethambutol causes red-green colorblind. So these adverse effects are really serious and they're very unique for the most, or they're very unique. So it's very easy for you to memorize them and they're just easy points for you to score on a test if you could just remember the adverse effects. Now here's an example of you being a third-year medical student and you're checking in on one of your patients who has been being treated for HIV. He's recently developed TB, so he's being treated for HIV and TB, and he was started on the right program regimen 3 months ago. But when with this check, his white blood cell count was significantly lower. What happened? So what you need to know is that some sort of drug that we added with the right regimen has affected the drugs in the HIV. So what we need to know is that he's probably on antiretroviral therapy, and now some of them do use the P450. Some of them do use the P450 enzymes, but we also know that rifampin over here, with the right treatment, can actually increase the metabolism of the P450. So what you get is a reduce in the concentration of all the other drugs. So they're not really working. So do you remember the alternative to rifampin for people who have HIV or people who are taking other drugs? It's going to be Rifabutin. Rifabutin is very important because it has less drug interactions. All right, thank you for tuning in and good luck.